Hello, I'm Matt Alamang, and I'll be talking today about stomach and intestinal dysmotility. I have no financial disclosures. The gut is overall controlled by intrinsically and extrinsically. It's intrinsically controlled by the enteric nervous system with over 30 different neurotransmitters, including many you know, the acetylcholine, nitric oxide, serotonin, somatostatin, cholecystokinin. The enteric nervous system is made up of two separate, including the submucosal and the myenteric plexus. The myenteric plexus is located between the circular muscle layer and the longitudinal muscle layer and is involved with mainly motor control. The submucosal plexus is also divided into two separate, the inner plexus, which controls mainly secretion, and the outer plexus, which controls motility. Extrinsic control from the gut is mainly by the autonomic nervous system, which includes the parasympathetics in green and the sympathetics in red. The parasympathetics are mainly stimulating motility and secretion using acetylcholine. This one also involves the vagus nerve or the 10th cranial nerve to most of the GI tract and is afferent sensory nervous fibers. The splanchnic nerves control the distal colon and rectum. As far as the sympathetics in red are mainly inhibitory via norepinephrine. They begin in the thoracolumbar spine, go out to the paravertebral ganglion, to the prevertebral ganglion, otherwise known as the celiac ganglion, the superior mesenteric ganglion, and the inferior mesenteric ganglion, and then out to the gut. There are some voluntary nerves that control. In blue on the left-hand side of the image, you'll see the hypoglossal nerve or the 12th cranial nerve that controls the hypopharynx and upper esophageal sphincter with swallowing. And at the bottom part, the pudendal nerve, which controls the external anal sphincter and helps with timing of defecation. There are a number of hormones that play a role, but we'll touch on each of these as we move through. So first, the stomach. Gastric motility has to do with the stomach controlling three main functions: receiving food, crushing the food into mostly a liquid nutrient suspension, and then emptying the suspension into the duodenum to help maximize nutrient digestion and absorption. The proximal part of the stomach serves as mainly a reservoir with a receptive and adaptive relaxation, and motility is mainly slow and tonic contractions. The distal stomach is the main actor with spontaneous contractions from the greater curve that originate in the interstitial cells of Cajal. Moving on, we have to talk about the migrating motor complex, which is a wave of electrical activity that propagates throughout the intestine while fasting. A full cycle takes anywhere from 90 to 120 minutes. It occurs in three phases. Phase one is no particular contractions. Phase two is a variable frequency contractions. And then phase three is the strong and organized contractions. These happen in the stomach, a maximum of 3 per minute. They also happen in the small bowel, but we'll get to that a little bit later. In terms of gastric emptying, the stomach treats solids and liquids differently. Liquids follow mainly an exponential curve. This changes with increasing caloric and osmotic density, which slows the gastric emptying. But a lot of liquid emptying has to do with tone of the proximal stomach and pyloric resistance. The solids show an initial lag phase where the food is ground to be approximately less than a millimeter. And then after that follows a similar curve to liquids in terms of gastric emptying. The pyloric muscle is at the most distal end of the stomach and is thought to be mostly open via ultrasound and manometry studies. The innervation includes intrinsics via the interstitial cells of Cajal and extrinsic via vagal neurons, which again are mainly afferent neurons arising from stress receptors. Finally, moving on to stomach motility testing. There's three main ways to test. The first and most common is the gastric emptying scintigraphy, which can be done as a solid or a liquid. We prefer the solid if possible. It is a technetium 99 sulfur colloid labeled meal, which consists of a low-fat egg, some toast and jelly, and a little bit of fluid. The liquid is an indium-based labeled meal, but less exact. The nuclear medicine images are taken at 1, 2, and 4 hours after the meal. The patients are instructed to fast overnight, the night before. They're told to avoid prokinetics and opioids for 48 to 72 hours. Their fasting glucose should be less than 280, as this can affect gastric emptying. And patients can move around in between images because it is quite a long test for them. This is an example of a normal gastric emptying scintigraphy. Over the left-hand side, you see the nuclear images, the outline of the stomach. On the right, you see the detection of the radiolabeled isotope in the stomach. And by 240 minutes, it's completely exited the stomach in a normal individual. In a patient with delayed gastric emptying, by 240 minutes, you can see that there's still some egg left, and this would denote gastroparesis or delayed gastric emptying. Delayed gastric emptying is defined by one of two criteria: either greater than 60% of the meal is retained at 2 hours, or our more preferred, greater than 10% of the meals retained at 4 hours. We really do prefer the 4-hour test, as it has more reproducibility to it. There is some evidence about rapid gastric emptying, but this is not well established, and is thought mainly to be less than 30% retention at 1 hour. Moving on to other types of motility testing for the stomach is a breath test that is a non-radioactive labeled carbon that is also ingested in egg with a saltine crackers and minimal amount of water. The stomach emptying is the rate limiting step, which makes this possible. The egg is digested, absorbed, converted into bicarbonate, and then converted in the lungs to CO2 and expelled and collected at 45 minutes, 150 minutes, and 180 minutes. This has only recently been approved in the United States and is not widely available at this point in time. On the image, you can see the black dots denote a normal range for normal gastric emptying for a breath test, and then the red axis denoting a gastroparetic patient. Finally, for motility testing, the most robust and complete, it would be the wireless motility capsule that many people call the smart pill. It's a fairly large capsule that measures pH, pressure, and temperature. This is ingested with a standard meal with a nutrient bar and a small amount of water. The patient is instructed to fast for the following 6 hours after ingesting. A receiver is worn around the waist from anywhere for 3 to 5 days until the capsule is expelled. And then they keep a diary and press an event button for meals, sleep, and bowel movements. Because of the large size, it does require a phase 3 migrating motor complex to exit the stomach. Stomach emptying is denoted by an abrupt rise in pH of greater than 3 units, and normal emptying from the stomach is less than 5 hours. As I said before, the advantage for the wireless motility capsule is that you can get information throughout the gut, and we'll talk more about each section as we go along. Some of the disadvantages, the large capsule for patients to swallow. It can cause capsule retention, which would necessitate surgery to remove. The patient does have to wear and return the data receiver, and we've had variable success with insurance approval for this test, and some patients end up paying quite a lot out of pocket to have it done. But it gives us a large amount of information, including gastric emptying study, the small bowel transit time, colonic transit time, whole gut transit time, and a combined small bowel and large bowel transit time. This is an example of a normal smart pill study. At the bottom in red, you can see the pressure measurement. Moving up, green is the pH, and at the top is temperature. The gastric emptying, as said before, denotes by a large spike in pH when it exits the stomach. And then moving along, you can detect the entry into the cecum by a drop in pH, that we'll talk more about later. This is an example of a patient with delayed gastric emptying and delayed colonic transit, where it took 18 hours for the pill to exit the stomach, denoted by the large spike in pH at that time period. Moving on to some of the pathology of the stomach that's related to motility. The largest and best studied is gastroparesis, which is defined as a severely delayed gastric emptying in the absence of mechanical obstruction. So it does require an EGD to rule out any other reason for delayed gastric emptying and not just an egg test or a smart pill study. There are multiple causes of gastroparesis, including medication, approximately 22%. This can involve anticholinergics, tricyclics, if they're on any opioids, and even cannabinoids. So many of our patients will have tried marijuana at some point, and we promptly instruct them that this does the opposite effect that we want if they do have gastroparesis. It does slow down their stomach. Some patients are diabetes related, approximately 25% of gastroparetics. Only about 5% of type 1s end up with gastroparesis, and around 1% of type 2s. And usually in the diabetic realm, these patients have had diabetes for greater than 10 years, and they have other sequelae of diabetes, retinopathy, nephropathy, peripheral neuropathy. They rarely, if ever, have isolated gastroparesis related to their diabetes. A small percentage of patients are post-surgical from a hiatal hernia repair or a Nissen fundoplication resulting in vagal nerve injury. And the vast majority of gastroparetics are idiopathic, though some admit to a viral prodrome. There are smaller subsets as kind of teased out from idiopathic over the last few years, including autoimmune, Parkinson's, connective tissue disorders, including Ehlers-Danlos. And as these become more prevalent, they're being studied more and more. To date, the largest epidemiologic study of gastroparetics was through the National Institutes of Health and the Gastroparesis Consortium registries over the last 10 years. Consisted of over 700 patients. The vast majority were females and non-Hispanic whites. And what they found was Hispanics and Blacks were more likely to have diabetic-related gastroparesis. Black patients were more likely to have higher nausea vomiting severity scores, required hospitalization, and use TPN more often than the other groups. And over time, females had more improvement than males in their gastroparesis symptoms. So moving on to treatments for gastroparesis, by and large, this is a medical management. So avoiding medications that cause delay, including opioids. Diet modification is always the first line. Small, frequent meals, soft, avoiding roughage, raw vegetables. Prokinetics are also used, including erythromycin, though this can cause tachyphylaxis, and the patient needs to have periods of being off the medication to have effects. Reglan or metoclopramide, though patients need to be counseled on the risk of pseudoparkinsonism that can be permanent. And less available in the United States now is domperidone. We only use it under research protocols because of the severe QT prolongation and arrhythmia incidence that's being studied. All of these work pretty well with diet modification. From time to time, patients have severe malnutrition and continued weight loss, and they require endoscopic placement of a post-pyloric core pack feeding tube. There are surgical adjuncts to gastroparesis, but by and large, this is not a surgical disease, and are not thought of as any type of cure. And we'll go over some of these now. So some of these patients that get post-pyloric nasogastric nasojejunal tubes have malnutrition, and it's surprisingly not as many patients as you think that will require permanent jejunostomy tube. These can be placed open or laparoscopic, whatever you like, and are not permanent a lot of the time. Gastric stimulators are another adjunct, surgical adjunct. This is a high frequency, low energy stimulation to the stomach smooth muscle wall. A pair of electrodes is implanted along the greater curve, approximately 10 centimeters proximal to the pylorus and 1 centimeter apart from each other. The mechanism of action is not completely understood. One of the larger randomized double-blinded crossover studies was performed in 2003 and did show a significant decrease in vomiting frequency. It's currently FDA approved under a humanitarian device exemption and is only available at certain centers around the country since 2000. It can be placed either open or laparoscopic with minimal ports, and then extending the largest port for implanting of the module and battery. So this is that first randomized control double-blinded study results from the blinded portion of the study. The patients underwent a 2-month randomization where the stimulator was turned on or off, and there was a significant decrease in the weekly vomiting frequency in combined diabetic and idiopathic patients, but no one group was better or significant. There have been other studies, randomized and large prospective trials. These have had variable results in terms of outcomes, and our group does not use it as often as previous, though there are some high volume centers around the country. Complications of the gastric stimulators include lead erosion in the stomach. Generator can flip and twist. The leads can fracture. As it is a foreign body, there can be an infection. And many of our patients that have them removed will explain they have a shocking sensation around their battery pack. These packs also have to be changed, as is a finite battery and cannot be recharged. Anywhere from 3 to 10 years, it has to be changed. Moving on to pyloric interventions, there's the more well-established laparoscopic pyloroplasty versus the newer endoscopic per-oral pyloromyotomy. The laparoscopic pyloroplasty is a Heineke-McCulloch's pyloroplasty that is a 4 to 5 centimeter longitudinal gastroduodenostomy. This is closed in a running or interrupted transverse fashion with absorbable suture. Sometimes in single or multiple layers, followed by an upper endoscopy leak test. Complications include gastric outlet obstruction, gastric leak, leading to abscess or even sepsis. The largest study to date was a 6-month outcomes, where many of these patients had improvement in their gastroparesis cardinal symptom index, which is a common research measuring tool that gives a 0 to 5 Lachert severity score for 9 common symptoms in gastroparesis. And of the patients that got gastric emptying studies after their pyloroplasty, this group reported 77% normalization of gastric emptying. In a more broader review, it reflects many of the similar numbers for both symptom improvement and normalization of gastric emptyings. Though long-term, up to a third of these patients do require other surgical adjunct procedures. Moving on to the newer endoscopic version of the pyloroplasty is the per-oral pyloromyotomy, also known as a G-POEM in the literature, because of its similar technique to the POEM procedure for achalasia. It consists of a mucosotomy, followed by a submucosal tunneling, and then pyloromyotomy. The mucosotomy is then closed with multiple clips that fall off in weeks to months. Um, to be sure, there are no long-term studies for this endoscopic version of the pyloroplasty, but the largest study to date was with our group, the first 100 cases, where we also had a significant improvement in the GCSI, improvement in gastric emptying, and normalization in the patients that got gastric emptying studies of 57%. We did try to do a comparison between our laparoscopic pyloroplasty patients and our POP patients, where we looked at all the pyloroplasties that were done between 2014 and 2017, and then conducted propensity score matching, 30 in each group, to similar POP patients. And what we found is the laparoscopic pyloroplasty had a longer length of stay, longer operative time, and more overall complications, including surgical site infection, pneumonia, and unplanned ICU admissions, all with similar GCSI symptom outcomes as well as gastric emptying study outcomes. The final end stage possibility for gastroparesis, though not widely pursued, is a laparoscopic near total gastrectomy that's similar to a laparoscopic gastric bypass, except the gastric remnant is also removed, leaving a duodenal stump. This is a much higher risk surgery than the other previously described procedures, including up to a 10% leak rate and 70% reoperation rate. Major complications can include bleeding, bowel obstruction, internal hernias. Moving on from gastroparesis, in terms of gastric dysmotility, there's dumping syndrome, which is a result of excessive nutrient exposure to the small intestine. Is usually a result of surgical complications from a partial or total gastrectomy, esophagectomy, vagotomy, or fundoplication. This is divided into two types: early dumping, which is the vast majority, and late dumping. Early dumping symptoms include cardiovascular, such as palpitations, tachycardia, flushing, sweating, and abdominal symptoms such as nausea, diarrhea, pain, and cramps. Late dumping happens 2 to 3 hours after a meal and has more hypoglycemic symptoms of hunger, weakness, tremor, sweating. Treatments for dumping syndrome include smaller, frequent meals, drinking fluids approximately 30 minutes after your meals, avoidance of simple sugars. Less often, thickeners are used to increase the viscosity of a meal, and even octreotide is rarely used, but these can cause gallstones and steatorrhea. Moving out of the stomach now into the small bowel. Small bowel motility, just to rehash, is during fasting controlled by the migrating motor complex that lasts anywhere from 90 to 120 minutes with the 3 phases. In the stomach, it's a maximum of 3 cycles per minute for phase 3 and up to 12 cycles per minute in the small bowel. The postprandial motility in the small bowel is highly variable and according to the meal and fiber composition, and is as such not well understood. For motility testing in the small bowel, there is also a breath test that's lactulose based. There is a scintigraphy, which is also indium or Tictesium 99 based, and the outcome being cecal arrival time or percentage filling the colon at 6 hours. There is limited data for this, and only extreme values giving anything clinically pertinent. And then, as explained before, the wireless motility capsule, a smaller pill, can be used to calculate the small bowel transit time by subtracting the cecal passage time and the gastric emptying time. The cecal passage time is denoted by a fall of pH by approximately 1 unit. The downside is of the small bowel transit time is also during a fasting state and may not be related to food transit time. Again, the normal small bowel study, you can see gastric emptying on the left with a acute rise in pH and the cecal fall of at least 1 unit of pH, and the difference being the small bowel transit time, or SBTT. Some of the limited motility pathology of the small bowel includes chronic intestinal pseudoobstruction, which is defined as an absence of mechanical causes and can be related to disorders of smooth muscle function, intrinsic innervation. Can also be related to disorders of the interstitial cells of Gall in the small intestine. Another disease pathology is small intestinal bacterial overgrowth, where the normal small bowel has less bacteria than the colon from these phase 3 migrating motor complexes. The cause of bacterial overgrowth is usually chronic PPI use or surgical blind loops, such as a Roux-en-Y. The diagnosis can be difficult in clinical practice empirically via cultures. The indirect measurement via breath tests is more common, but the treatment for overgrowth is usually a short course of antibiotics plus or minus prokinetics. Finally, moving on to the colon. Colonic anatomy. The colon has two primary functions: to reabsorb water and electrolytes, as well as storage of feces. There are two types of muscle fibers, longitudinal or tinea, and the circular pouches known as haustra. The innervation of the colon that we talked about before was the right colon mainly from the vagus nerve, the left colon from pelvic splanchnic nerves in the parasympathetic system. The sympathetic control of the colon is mainly perivascular plexuses. There are a few hormones that are known for colonic stimulation with gastrin and cholecystokinin, as well as inhibition with glucagon and vasoactive intestinal peptide. Colonic motility in general has two main groupings: the haustrating or segmenting contractions. This is local circular muscle contraction that's slow with variable duration and amplitude. And this is mainly for mixing stool to optimize water and salt reabsorption. This is increased after a meal and does stop at night. The other type of colonic motility is a mass contraction, also known as high amplitude propagated contractions, or HAPCs. This is a prolonged circular contraction that propels toward the anus about 1 centimeter per second. There are approximately 6 of these per day. The first usually happening in the morning and usually after meals after that. Finally, to circle back, there is a gastrocolic response that appears 30 to 60 minutes of increased activity after a meal, and is thought to be related to cholecystokinin and gastrin, as well as increased autonomic nervous activity. Motility testing for the colon, different from the stomach and small bowel, is the radiopaque markers. This is a capsule or a meal containing beads or rings that are radiopaque. And then the patient undergoes serial abdominal x-rays that are timed. There are multiple protocols for this across the country, and with a lack of standardization, it's difficult to compare. But in general, the mean colonic transit time is around 30 to 40 hours with a maximum of 70 hours. The maximum colonic transit time is different between the sexes, where women are longer, anywhere from 70 to 106 hours, and men max out closer to 50 hours. One thing of note that we'll talk about a couple of times, but is beyond the scope of this talk, is it is also important to exclude anorectal pathology, as this can slow down colonic transit time. This is an example of radiopaque markers. After 120 hours, you can still see the radiopaque rings in the right colon and likely sigmoid colon. This was after a patient ingested a capsule with 24 radiopaque markers included. There is a colonic transit scintigraphy, much like the stomach and small bowel. This is indium related via a solid liquid meal or a charcoal containing capsule that dissolves in the alkaline terminal ileum environment. This is only done in a limited number of centers. The top two images, an example of normal healthy colonic transit time, and then the bottom two are a delayed colonic transit time. And finally, to circle back around for the smart pill, the CTT can be calculated. And most of the patients, approximately 5% of patients, the cecal entry cannot be detected, meaning they don't detect a drop in the pH. In this case, an indirect measurement of combined small and large bowel transit time can be calculated from gastric emptying to exiting of the capsule from the body. Finally, the pathologic motility of the colon. Constipation is a very common affliction in North America, as many as 63 million people. Women are 2 to 3 times more affected than men. There are roughly 3 subtypes: slow transit constipation, normal transit constipation, which includes IBS with predominant constipation, as well as pelvic constipation. These can occur in isolation or in combination. A convenient workup and treatment algorithm shown here consists of patients that come into your office with constipation, a focus history and physical with labs. If a colonoscopy is indicated for other reasons, it's usually undertaken at this time. And then medical treatment with fiber and laxatives, which we'll touch on in a movement. If there's no improvement, then that's the point where we usually move on to colonic transit testing that we already talked about, and pelvic floor studies, but we won't be talking about that during this particular lecture. Another way to describe both in the research and with your patients is by the Bristol stool scale. So the consistency of the stools ranging from separate hard lumps in type 1 all the way down to watery or most entirely liquid down to type 7. A convenient framework for functional bowel disorders, not just constipation, was released via the recent Rome 4 in 2016. You can see constipation denoted towards the top part of the graph, diarrhea down towards the bottom. As you move firmer from left to right, you have the functional constipation and diarrhea on the left, and then more pain-related symptoms with IBS over on the right-hand side. There's often significant overlap between all of these disorders. Moving on to specifically functional constipation, which is defined by Room 4. It must be 2 or more of the following: straining, lumpy or hard stools, sensation of incomplete evacuation, sensation of anorectal obstruction or blockages, the necessity of manual maneuvers, including digital evacuation or pelvic floor support, in greater than 25% of defecations. Can also be defined as fewer than 3 spontaneous bowel movements per week. Loose stools are rare unless using laxatives, and there has to be insufficient criteria for irritable bowel syndrome, which mainly consists of pain. For functional constipation, the incidence of both the house draining and mass contractions has decreased. And on biopsy results from explanted colons, there is a decreased number of neurons in the intramural plexuses, but it is unclear if that is the cause or a consequence of the pathology. Regardless, treatment of functional constipation is mostly medication, elimination of medications that may be causing the constipation, increasing fluids and fiber. If these fail, adding an osmotic laxative, including Miralax, magnesium oxide, though this should be avoided in patients with renal insufficiency, or lactulose, but this does cause increased gas production as it is a substrate for colonic bacteria. If the osmotic laxatives do not help, then adding a contact laxative for direct stimulation of the colon, such as bisacodyl or acinosides, can also be helpful. A brief aside about Ogilvie syndrome or colonic pseudoobstruction is denoted by an acute colonic atony. The obvious mechanism is unknown. On X-ray, you'll see unmarked dilation of the colon and cecum. This is often seen in elderly patients with severe illness or post-operative after a joint replacement. The treatments are medical support, electrolyte optimization, as well as colonoscopic decompression or neostigmine, though this medication should only be given in a critical care setting, as the risk of bradycardia and bronchospasm is often. To talk more about motility, patients with slow transit constipation or colonic inertia need a transit study that we talked about earlier. Again, the first line of treatment is medical and is pretty successful most of the time. Surgery can be considered, but only after complete exhaustion of the medical therapy. And there is some evidence that if patients have isolated colonic inertia and no upper motility signs, that they have better surgical outcomes overall. But emphasizing patient selection and realistic expectations are keys to a reasonable outcome in this patient population. Again, the image is a patient, an X-ray 5 days after injection of the radiopaque markers. So the surgical treatment, the main and most well-studied option is the total abdominal colectomy with ileorectal anastomosis. The largest case series review was a large group of case series that was heterogeneous in workup and technique. Success has a wide range, but resulted in a median daily bowel movement of around 3. There was an incidence of recurrent constipation in up to 33% of patients, abdominal pain, 40% of patients, permanent ileostomy in about 5% of patients, and the risk of small bowel obstruction and reoperation should definitely be part of the preoperative consent with the patient if this is being considered. There are isolated case studies in segmental colectomy and proctocolectomy with IPAA, but this is few and far between and has been used in highly selected patients only. Other options for surgical treatment of colonic inertia include ileostomy curation in folks that have failed their colectomy, and up to 25% require one. In folks that wouldn't tolerate a colectomy, or those that suffer from fecal incontinence at baseline. A loop ileostomy has also been described as a prequel to colectomy in patients you suspect may have a gastric or small bowel dysmotility as well. Um, the antegrade colonic enema option is more often used in children and less well in adults due to the high revision rate for stenosis and catheter dislodgements that are associated with this particular intervention for colonic inertia. Moving on to diarrhea, this can be difficult to define. It's been thought of as a higher frequency of defecation, a larger weight per day of stool, and has also been described in terms of the Bristol stool scale that you can see below for type 6 and 7. Overall, it's thought as a decrease in water resorption by either the colon or small bowel, and many disease processes can be subdivided into osmotic or secretory. And the concept of motility being the issue is diagnosis of exclusion. The Rome 4 criteria of functional diarrhea includes loose or watery stools without a predominant abdominal pain or bothersome bloating in greater than 25% of the patient's stools. Finally, for completeness sake, we'll talk about irritable bowel syndrome. This is a completely medical disease, but abdominal pain is the predominant symptom with either constipation, diarrhea, or alternating mixed symptoms. The Rome 4 classification for IBS is recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following. The pain is related to defecation, either caused by or relieved by. It is associated with change in stool frequency or form or appearance. It has to be present for the last 3 months with symptom onset at least 6 months before diagnosis. Useful graph to think about the different predominant types of IBS. Being clear that 20%, greater than 25% of the bowel movements should meet some threshold category for each type. And treatment is more focused around medications to alleviate the main complaint of the patient. So if they come in with a mainly diarrhea type of IBS or even functional diarrhea, you want to try opioid agonists such as loperamide, a diet low or gluten-free, as well as a low FODMAP diet, which stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. This is some fruits such as apples and pears, sweeteners, milks and cheeses, vegetables, wheat and rye, legumes, and avoidance or decreasing this in the diet may help. Adding bile salt sequestrants such as cholestyramine can be help. Probiotics, antibiotics like rifaximin, and serotonin antagonists have also been helpful in the diarrhea predominant IBS. If they mainly complain of constipation, you can use a mixed opioid agonist or antagonist, psyllium or Miralax, as well as lubiprostone or Amitiza, or linaclotide, also known as Linzess, to help with the constipation symptoms. And finally, if pain is the patient's predominant complaint, there are a number of options, including smooth muscle antispasmodics, peppermint oil, tricyclic antidepressants, SSRIs, as well as the Amitiza. Linzess has been tried as well for many patients with reasonable outcomes. Finally, you can try serotonin antagonists. That is the basics of gastric and intestinal dysmotility. The main emphasis I'd like you to take away with is these disorders are often encountered in surgical practice. They are still largely medical diseases, though we do have some surgical options to help these patients to alleviate some of their symptoms, but only after this is exhausted. Thank you very much.